Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Maria Junaidi, and I'm a stroke neurologist practicing in Dubai, UAE. I am the General Secretary for the MENA Stroke Organization, and it is my very great pleasure and honor to welcome all our renowned guests and delegates to the 6th session of the MENASO Education Academy Cerebrovascular Grand Round Series 2023. The series is organized by the MENA Stroke Organization, which is a region-wide non-profit organization that is committed to furthering the cause of stroke and to reduce the overall burden of stroke in our Middle East, North Africa region. This Education Academy Cerebrovascular Grand Round Series is endorsed by the World Stroke Organization, by the Pan-Arab Union of Neurological Sciences, by the Sheikh Khalifa Stroke Institute, Johns Hopkins Medicine, and the American Stroke Association. Today's webinar is going to be centered around 2 talks, the first of which is about developing stroke clinical trials network, and the second will be centered around the use of advanced imaging for treating stroke cases. A few housekeeping rules. This will be an interactive session, so we will be having a dedicated question and answer session at the end of it. Once both of our esteemed speakers have completed their talks. We encourage all our attendees to post their questions about the 2 topics that we are discussing today in the Q&A box, and we will try to get to most of them at the end of the session. Now, first things first, I would like to introduce my co-chair. It is my very great pleasure to welcome Dr. Mohamed Alzawahmah to this Cerebrovascular Grand Round. Dr. Alzawahmah is a highly accomplished vascular neurology consultant and neurovascular integrated practice unit director at King Faisal Specialist Hospital and Research Center. He obtained his MBBS from King Saud University and pursued specialized training in neurology, stroke, neurocritical care, and EEG at prestigious institutes like the University of Calgary and the Western University. Dr. Alzawahmah furthered his education then with an executive master's degree in healthcare facilities administration and hospital management from King Abdulaziz University. He has also completed a diploma program in healthcare quality management and patient safety in collaboration with the Joint Commission International. With this diverse educational background and his extensive experience, Dr. Alzawahmah is dedicated to providing exceptional patient care, conducting research, and advancing neurovascular medicine. Very warm welcome, Dr. Alzawahmah, and over to you to introduce our first speaker. Thank you.
Thank you very much, Dr. Junaidi, for introducing me and for introducing the session, starting the session. First of all, I want to welcome Dr. Jayaraj Bandian. Dr. Bandian will present developing stroke clinical trial networks, lesson learned from stroke clinical trials instruct. Dr. Bandian is a professor and head of neurology and the principal dean of Christian Medical College, Ludhiana, Punjab, India. Dr. Bandian is the current president-elect of the World Stroke Organization and past president of Indian Stroke Association. He is a fellow of the Royal Australian College of Physicians, fellow of the Royal College of Physicians, fellow of European Stroke Organization, and fellow of World Stroke Organization. Dr. Bandian was the past chair of World Stroke Campaign, International Working Group of World Stroke Organization. He has been a member of World Stroke Organization Policy and Research Committee. Dr. Bandian was the co-chair of the World Stroke Congress in 2016, held in Hyderabad, India. He is a member of the Strategic Advisory Group for NCDs in WHO Geneva. Dr. Bandian was conferred the World Stroke Organization Global Stroke Service Award in 2020 for his contribution to the field of stroke. Dr. Bandian has made significant contribution to care services, epidemiology, and thrombolysis in low and middle income countries. He's the national PI for Indian Stroke Clinical Trial Network Instruct. He has more than 236 peer-reviewed publications. Without any delay, I welcome Dr. Bandian, and you can start your presentation. You have 30 minutes.
Yeah, thank you, respected Dr. Mohamed, and thank you for the introduction. And so you can see the screen?
Yes, Doctor, we can see the screen.
Thank you.
Yes,
first of all, I thank the MENASO Academy, Education Academy, for inviting me to give this talk. So what I'm going to do is talk about stroke clinical trials and how it is important and what all networks that we have globally, and also talk about the Indian Stroke Clinical Trial Network. So this is about the global stroke trial networks that we have. One is NIH StrokeNet in USA, which has more than 450 hospitals, and they have more than 25 regional stroke centers, and under them there will be multiple hospitals. And the second one is the National Institute of Health Research, UK. They have more than 200 hospitals in the network, stroke centers basically. The Canadian Stroke Consortium and Canadian Stroke Network, the Australian Stroke Trials Network, the European Stroke Organization Trials Alliance is a network of multiple European networks under one umbrella. Then we have a global network, basically a global alliance of networks in strokes, where all the stroke clinical trial networks, we meet quarterly and then see what are the trials that we can do globally and how we can access funding from different countries. The stroke research in India largely has been in observation studies. If you look at the last, I would say 20-25 years, a lot of registries, population-based stroke registries, hospital-based stroke registries, case control studies, and there are several genetic studies, some basic sciences studies, but no large-scale stroke trial designed and funded in India. There are many global trials. They will come to India with a small funding, and a few centers in the country used to recruit patients for the trial. So the history of INSTRUCT, that is the Indian Stroke Clinical Trial Network, it started somewhere in 2013 or 14 when I had the idea of this family-led rehabilitation in stroke, using the caregivers, how we can deliver stroke rehabilitation in their home. So we did a pilot study with support from George Institute of Global Health, Australia, Sydney. And in our center, we were able to recruit 104 patients. The intervention arm patient received training. The caregivers received training from the physiotherapists to deliver the rehabilitation in their homes. Then with NHMRC funding in Australia, we were able to do this large trial, ATTEND trial. We recruited 1,250 patients from 14 centers in our country. And this is probably the second largest stroke rehabilitation trial in the world. And the model is that training the caregivers by the physiotherapists, and they'll deliver the therapy at home, monitoring done and documentation done for the first month, and then a blinded assessor assess the outcome at 3 months and 6 months. This trial was neutral in terms of results, but we were able to show that the task shifting with the caregivers is possible. But there are several lessons that we learned from this trial, which is really helping us to come up with some newer ways of tackling stroke rehabilitation in India. So after the trial was presented in World Stroke Congress in 2016 in Hyderabad, in November, first week, we had a dissemination of the results with the policymakers in New Delhi. At that time, the top policymakers of the country, they came for this meeting. half-a-day meeting, and we were able to discuss. And that really helped the top policymakers, Dr. Soumya Swaminathan, who's here. She was a former Director General of Indian Council of Medical Research. So I was talking to her that this particular network that we have created with 14 centers, it should not just collapse after the funding is over. But I requested her that whether we could get funding from ICMR to increase the number of centers in the network, and with Indian funding, we could be able to do trials in India. So the objectives of INSTRUCT was to create an infrastructure to conduct large stroke clinical trials, to conduct simple pharmacological and non-pharmacological stroke clinical trials which are relevant nationally and also globally. So phase 1 started in 2017 to 2022. We completed 2 trials. I will be discussing that. And phase 2 started last year, in the middle of last year, 2022 to 2027. 4 trials have been initiated. So what is the governance and infrastructure? So INSTRUCT has 2 major governance infrastructure. One is the steering committee of experts created by Indian Council of Medical Research, and then the nodal center for coordination. So we are the national coordinating center, and there is another center for southern part of the country where they coordinate the centers in the southern region. Then we have a central coordinating center is our center, then trial monitoring center. So we have for region-wise, we have created. They send the staff for monitoring the trials in these centers. Then we have the individual sites. We have the data and safety monitoring board and the international advisory committee as well in INSTRUCT. So criteria for participation in the network, there should be a stroke center and a functioning stroke unit. The last 2 years, minimum volume of about between 100 to 200 stroke patients in a year, and some experience in participating in clinical trials or some clinical research. And the PI should be able to deliver this, the participation and recruitment of patients using good clinical practice guidelines. And this workflow summarizes how it all started with multiple expert group meetings, and then we created the network, applied for funding, and there was multiple peer reviews. For the first, for the phase 1, we had about 7 trial proposals, and finally 2 were shortlisted by the experts group, and we rolled out the first trial in April 2018, and the second trial in April 2019. So this paper, which we published in Stroke Journal 2021, if any of you are interested, you can download this paper, which gives all the details about the INSTRUCT, from the way it started, the governance, and what are the policies and SOPs, etc. So currently there are 55 centers in the country from most of the regions of the country, both government hospitals, private academic teaching centers, government academic teaching centers. These are the steering committee members, and mainly consisting of clinical researchers, very experienced people, basic science researchers, and public health experts. Our first investigator meeting was held in May 2017 in Hyderabad. This was a small beginning, I would say, where we were able to bring all these investigators together with the steering committee members, and we discussed, we presented multiple ideas and trials, and finally 2 trials were shortlisted in this meeting. And in addition, we try to have every 2 years a capacity building workshop. The co-PIs in the network should not be left out. It's not that few PIs are dominating the network, but we gave opportunities for all the co-PIs in the network. So after this capacity building workshop, which is about 2 days, where experts from across the country came, including a biostatistician, there was a mock trial presentation, mock proposal writing, sample size calculation, some basics of statistical analysis. This workshop was so good that every co-investigator PIs were able to participate, and learn about clinical trials. Then we had a joint meeting with NIH StrokeNet. This is another landmark meeting in September 2019 before the COVID. It was a 3 days combined meeting where NIH StrokeNet shared their experiences and we shared our experiences. And for the phase 2 of INSTRUCT, there were about 10 trials that were presented, and the experts from NIH StrokeNet and ICMR, they sat together, they assessed the trials, and finally 4 trials were approved for phase 2. So phase 1 trials, first one is a secondary prevention by structured semi-interactive stroke prevention package, Sprint India trial. I was the PI for this trial, basically to reduce recurrent stroke, acute coronary syndrome, and deaths in patients with acute stroke with the help of SMS, video message, and workbook. In subacute stroke, basically, and it's a randomized controlled trial, parallel design, and blinded outcome assessment in subacute stroke patient. When they were medically stable between 2 days to 3 months, first ever stroke patient with MRS 2 to 5 were recruited, and they should have a mobile cellular device. And a patient with aphasia or illiterate, the caregiver should have a mobile, and they should be able to read and write. So in the intervention arm, if they are randomized, they receive regular text messages. About 70 text messages were prepared, and the first 6 weeks it was sent daily, and then at frequent intervals. Then the 7 health education videos were sent weekly, and they had to review. And stroke workbook which had multiple activities for every week, and they have to complete those activities, and at the end of the activity they need to give their feedback. And there was telephonic calls the first 6 weeks, and thereafter 6 months and 1 year. The outcome was assessed at 1 year. The control arm received standard of care management. They had follow-up telephonic calls. The primary outcome was a composite endpoint of recurrent stroke, high-risk TIA, ACS, and death, and vascular death, basically. And there was a variety of other secondary outcome measures. So the results, so we were able to screen more than 5,600 patients, and 4,298 patients were randomized. And at the end of 1 year, 2,148 patients were included in the intention treat analysis. So this is a basic demography which is similar in both the groups, and it is well balanced. This is the primary outcome. The vascular events were less. There was no difference between the two groups, but the secondary outcome, particularly the current alcohol intake, current smoking, alcohol cessation, was reduced in the intervention group, and the medication compliance was also better in the intervention group. The trial was stopped by the DSMB for futility when we did an interim analysis, and so there were some positive secondary outcome in terms of behavior and lifestyle changes. So this was published in February this year with a very good editorial on looking at the use of mobile health for secondary prevention of stroke. The next trial that we completed recently is the Ayurvedic treatment and the rehabilitation of ischemic stroke patients in India, a randomized controlled trial. Dr. P.N. Shailaja was the PI, I was the co-PI, and we presented the results in the European Stroke Congress, which was held recently. We know physiotherapy is the mainstream for stroke rehabilitation. However, many of our patients, particularly from South Asia, Southeast Asia, they go for alternative medicine. In India, more than 50% of our patients go for Ayurveda and the traditional Indian medicine. So it has not been tested in a very scientific way. So the following objectives, we evaluated the safety and efficacy of traditional holistic Ayurvedic treatment as compared to the conventional physiotherapy in ischemic stroke patients. So if they are randomized to the Ayurveda arm, they receive the therapy in a separate Ayurveda hospital for a period of 1 month, and they had weekly different therapies like induced sweating, medicated enema, steam therapy, and oil massage, and herbal medicines, etc. And They also received some oral medications, which were all standardized for all the centers. Hypothesis was Ayurvedic treatment is superior to conventional physiotherapy. It was a multicentric, randomized, 1:1 open-label blinded outcome assessment trial. So inclusion criteria was patient between 18 to 70 years of age, first ischemic stroke patients, 1 to 3 months from stroke onset, and they should have MRS 3 or 4 at enrollment. And we had excluded many patients with multiple comorbid conditions. The primary outcome was Fugl-Meyer assessment, improvement in score at 3 months, and they had Barthel index, Berg balance scale, quality of life scales, etc. So the sample size was 140. After 1 month of intervention, both in the intervention arm and the physiotherapy arm, they were asked to continue physiotherapy as a standard of care. And the first month and the third month, the follow-up was done by blinded assessors. The study was done in 4 Indian sites, 3 South Indian sites, and one site was from our center. So study results. So we screened about 403 patients, 140 were randomized, and finally 60 completed 3-month follow-up in the intervention arm and 65 in the control arm, and 125 included in the intention to treat analysis. So the baseline characteristics were similar in both the groups in terms of age, gender, and the risk factors. And these are the different scores, which are also pretty balanced, and this is the primary outcome. There was some improvement in the physiotherapy arm in terms of Fugl-Meyer score, but however, this in unadjusted it was significant, but in adjusted it was not significant. We also looked at the time point change from baseline to 3 months in individual groups, and that was also significant in the physiotherapy group in the unadjusted analysis, but adjusted analysis it was not significant. The variety of secondary outcome measures, Barthel index improvement was seen in the physiotherapy group in the unadjusted analysis, and similarly for the time point analysis. So many people say that Ayurveda treatment is without side effects, but what we are able to see is that the adverse effects and SAEs was seen or similar in both the groups. And there were 3 deaths in the Ayurveda group. When the ethics committee looked at it, they mentioned that it is not due to the treatment. So this is the first randomized controlled trial involving 2 systems of medicine. It was so difficult for us to bring both the systems together and to come up with a common protocol. So one is the Ayurveda treatment is not superior, and Ayurveda treatment is safe. That's all we can say from the trial. This is the first ever trial properly conducted with in a randomized control manner in the environment, and proper outcome assessments were used, and the standard protocol was used. Limitation, maybe a small sample size, but it is so difficult to deliver this therapy, and due to availability of the infrastructure. So these are the collaborators. This is the Ayurveda group as well as our INSTEC group. This is a publication with the protocol. The phase 2 trials, I'll quickly go through the phase 2 trials that we had. We had the investigators meeting in Goa last year, the same time. And this is an intrinsic trial, a tranexamic acid injection within 4.5 hours. And the PI for this, about 50 centers are involved, 3,400 the sample size, 4-year study. Primary outcome is death at 7 days, and the secondary outcome are MRS and few other outcome measures. And mobility is basically looking at the post-stroke care using an app to prevent bed sores, pneumonia, UTI. And there was a pilot trial done by Dr. Dheeraj Khurana, and we have expanded this. It's a 3-year trial. The app is under construction now. Probably in 2 months' time, it should be able to start the recruitment. Then Reopen is basically a biosimilar TNK. India is the first country in the world to approve TNK, which is a biosimilar one, in 2016 for acute ischemic stroke. So we are comparing as a bridging therapy, biosimilar TNK versus TPA in people with LVO within 4.5 hours. So this trial, the sample size is 372. Dr. Rohit Bhatia as the PI is 3 years as a duration. Stenosis is basically looking at the double antiplatelet therapy versus single antiplatelet therapy after 3 months of double antiplatelet therapy in people with ICAD and ischemic stroke. The sample size is 2,200 and the outcome is recurrent stroke at 12 months. So this is the current status. Intrinsic trial, 590 patients have been recruited. We started the recruitment sometime in October last year. Stenosis is 101, reopen 51, mobility starts soon. So the budget, if we look at phase 1 for 2 trials, 13 crores, which is close to 1.7 million USD, and for phase 2, 4 trials, 19 crores, 2.5 million USD. We also do other clinical trials, global trials. We have done Enchanted PP Arm, Head Pose, Interact 3, which was published recently in Lancet, and Overdose, which is ongoing. Enrich AF is basically giving a patient with ICH and AF edoxaban versus antiplatelet therapy. Prospect is looking at the long-term cognitive outcome in stroke patients. So challenges and lessons learned. One is to convince a funder. It took 2 years. Teamwork, you need to have people with in the group who are keen to participate and contribute. Equal partnerships. So every PA was given an opportunity to come up with an idea and write a grant proposal and submit. So it's a competitive grant review process. Capacity building also we have been doing frequently. Participation in global trials give them a lot of experience and also help them to develop some corpus for research. And we have a clear publication policy in place so that after the primary paper for a trial is done, all the other co-investigators are encouraged to submit their ideas and for secondary papers. So there is a proper partnership and collaboration. So I sincerely thank all the former Director Generals of ICMR and the NCD division staff who have been really supportive of this network. Thank you very much.
Okay, thank you, Dr. Pandian. That was very insightful, and I'm sure there's some interesting questions that the audience will also have. I have a few as well. We'll come to them after this next talk. So I'd request if you could stay on for a bit longer with us. Okay, thank you. So our next speaker is Dr. Van Assiraf. Dr. Assiraf is recently accredited as a consultant neurologist in August 2019. And prior to that, he was working as a consultant physician since 2016 in the first public university hospital that has a stroke care unit and has a stroke reperfusion service in Malaysia. He is also a clinical lecturer in internal medicine and neurology and has a keen interest in stroke. He did a short attachment at the Comprehensive Stroke Centre, Royal Melbourne Hospital in Melbourne, Australia. And currently, Dr. Assiraf is the president of the Malaysian Stroke Council. He has a special interest in stroke prevention and hyperacute stroke imaging, and he is currently the national lead investigator for the Trident clinical trial and the co-national lead investigator for the Evert Dose trial. Dr. Assiraf is involved in training the trainer in the ASEAN for hyperacute stroke protocol, and he's involved with stroke reperfusion service establishment in the Maldives as well. It is my very great pleasure to welcome Dr. Assiraf, and he will be discussing a few cases that were assisted by advanced imaging for stroke treatment. Over to you, Dr. Assiraf.
Assalamualaikum, a very good day. Thank you, Maria, for the kind introduction. And thank you for the invitation to the Educational Committee, MENASO. Can you listen to me?
Yes, we can. Please go ahead.
Okay, so share my screen. I'll just do a quick introduction on my talk today is on stroke cases treatment assisted by CT perfusion. And yeah, I'm actually the vice chairman of Malaysia Stroke Council. So these are my disclosure, none for today's talk. So just a quick one. We know stroke is clinical syndrome as a result of a vascular blood supply disruption. So in our National University of Malaysia protocol, CT brain plane, CT perfusion, and CT angiogram arch to aorta to vertex is within our protocol. And I put this in red because of this is at least the minimum in this era, CT brain plane, and then followed by CT angiogram arch of aorta to the cerebral cortex or the vertex. So you can read through optimal imaging at the primary care stroke center by my mentor, Bruce Campbell, published in 2020. Okay, so why CT perfusion? So CT perfusion provide immediate, preferably with a good immediate information as mentioned here. So preferably with a good clinical correlation, require a bit of experience and training. CT perfusion will provide fast, accurate diagnosis. So you immediately recognize easily a stroke mimic. This is one of the things we know. Some of the patients come with poor GCS and maybe a bit difficult to get the history. In the uninitiated eye or a bit more less experienced, sometimes the partially occlusive large vessel occlusion can be missed. However, it's common also in the experienced hand, medium and distal vessel occlusion will be missed. With a CT perfusion, this is easily picked up. And the second one will be provide prognostication, aiding communication to patient and relative, and precision of management that I will show later. CT perfusion cannot be interpreted on its own. So you need to have a good clinical history, if possible, then CT brain plane, then the CT perfusion and CTA. It allows us to understand neurovascular physiology of the brain. It's not just about the penumbra. Although I told you just now, it's not all about penumbra. Neurovascular physiology status, what I meant here, it can be as benign or leukemia. It's not really benign, where there's prolonged MTT, TTP, and delay time. However, if you look at the picture later on, there will be discrepancy of the maps. So it's not correlating or concurring to each other. It's a normal CBV and CBF, and there's no clinical symptoms over here. With critical hypoperfusion, there's prolonged MTT, TTP, and delay time with symptoms. And if you have a patient with normal CBV or normal or slightly low CBF, this is the predicted penumbra. And for the low CBV and low CBF, then this is predicted core. So I put in red again here, this is a predicting model. So therefore, it is not accurate if you get a spontaneous reperfusion or recognition, or you manage to basically get a procedure being done or reperfusion therapy being given. Hyperperfusion can happen with or without reperfusion treatment, where you can see increased CBV, CBF, and may happen despite abnormal CT plane. So meaning there is already infarct, but there is a reperfusion or other differential diagnosis. So we most of it here, clinician, it's easy for us to know whether this is a MAPS of a seizure or a tumor. So we start with the case 1, 62 years old patient, guy, diabetes, hypertension, dyslipidemia, known case of ischemic heart disease, and he had a previous stroke about 4 months prior, however recovered fully and noted to have atrial fibrillation, and the bigatron was within 12 hours from the last dose. The blood pressure is okay at 140/90, so slightly highish, but not too bad. The heart rate is rate control AF, 90 beats per minute, and glucose is 6 millimole per liter, and this is acceptable. However, he arrived at clear onset 5 hours prior, and the angio suite was occupied. There's left gaze preference, aphasia, and right hemiplegia. The NI chest upon arrival was 24. So I stop sharing this slide. Oh, sorry. Okay, so this is the CT scan plane for this patient. I'll just put this one up. Okay, so have a look on the left side over here. So this is a patient that arrived at 5 hours. Okay, we go from below. So there's no more than 1/3 MCA established in FARC. And if you believe in aspects, then the aspect score is not too bad. And if you look at during our stroke protocol, most of the time we just go with CT perfusion first while processing of the CTA. Sometimes the CTA will come also quite early. So this is within about less than 6 minutes and can go up to 10 minutes. But this is at 5 hours. So we need CT perfusion at the moment. So if you look at the CT perfusion, I'll go to the ganglionic level. So despite the scan just now, you see the CBV. This is the CBV. This is the summary maps. This is the time to peak, and this is delay time, and this is the MTT, and this is the CBF. So you can see from the time to peak, the MTT, called the delay time and the MTT. So it matched at the superior division of the MCA. But if you really look through the maps properly, there's also prolongation of the time to peak and delay time. However, MTT with the noise, you can see it throughout the MCA. We'll check on the CTA later. However, you look at the CBV over here. So with our machine, Accredited 1, you can see that the CBV is not too bad. So the predicted core here is not that much. And the ratio of penumbra in this case calculated by our scan is actually significant. So that's luxury penumbra in this case. However, if you look at the CTA while I was scrolling just now, the stump is actually at the distal ICA or proximal MCA. So you basically wanted to see a large MCA. So in this case, remember just now, this patient had a called stroke about 4 months prior. It was mild and improved within the 4 months and MRS 0 because of there's a distal stenosis. So due to the distal stenosis, the patient had good collaterals, and this time around, the patient had AF stroke on the background of ICATs. So we traumatized this patient based on extent, and after about completion of the IVT, so basically this patient was on the dabigatran, so received idarucizumab, 2 vials, then immediately we'll then lyse this patient with altiplase. Then following that, we then proceed with thrombectomy. So this is a thrombectomy outcome. So thrombolysis is about 5.5 hours. And on the left-hand side, you can see my screen. So this is the called EVT. So we can see it's concurring with the CTA just now. And prior to the thrombectomy, the NIHS from 24 improved to 15 for a while. So maybe there is a partial recanalization. After that, this is the DSA, and this is about 2 pass thrombectomy. Then you see there's reperfusion of the MCA. So this is the scan. Just need to make it bigger, sorry. Okay, post-reperfusion. So 1 hour after the EVT, this patient NIHS from 24 highest, it goes down to 8. And after 3 days, it goes down to NIHS of 1 with just mild facial symmetry. So this is just a contrasting. So the patient comments back on the anticoagulant. In this case, we practice single antiplatelet for 3 months. That's off-label at the moment. Okay. You proceed with the case 2 first, Maria. Okay, so case 2, 51 years old. This one is a guy, so 51 years old guy with blood pressure 140/90, and heart rate was regular upon arrival, and glucose was 6 millimole, and the clear onset 3 hours prior. Clinically, left face and hand weakness, which is mild, and by criteria, this is non-disabling NIHS 2. We know about PRISM trial at 90 days where altiplase versus aspirin, there's no significant benefit of the favourable outcome. So basically, we know that also this study was halted prematurely. So basically, if you look at the criteria, will you treat this patient? So this is a patient scan. So if you look at the CT plane here, now you're already seeing the CT perfusion. So this is a recent case. So basically, this patient had a 1 millimeter CT scan. So I'll just go to the gangway level. You just need to believe me, there's no wanted MCA in this case. And aspects is quite good. You already saw the CT perfusion here, can be biased, but this is 3 hours. So you see the CT perfusion over here. So we know that this is at 3 hours from onset. And this is the CT with CT perfusion like this. So this is a cortical stroke. This is again the time to peak. This is a delay time. And this is the MTT. The CBV is quite low. However, this is at 3 hours from onset. We know CT perfusion is not validated for this. However, as I mentioned to you just now, prognostication with this CBV low, if there's late recanalization, one of the risks of this area is basically reperfusion edema or also reperfusion hemorrhage because of this looks like cortical thromboembolic or thrombotic. So what is your decision? This is non-disabling stroke. I'll just show you to you immediately the proximal vessel is not occluded. Yeah, so just follow through the MCA. It's not occluded. Yeah. Okay, just a quick one. So again, off-label, but I think you can use CT perfusion in this case to lead your treatment judgment. So in our center, because of with this cortical stroke like this, and we thought that this is likely cardioembolic. So then we discuss with the patient. So this is patient to patient, called this case to case basis, and the patient agreeable for the reperfusion therapy. So NIHS 2 didn't progress. This is the post repeat scan. One will argue maybe there's a petechial hemorrhage, but clinically is asymptomatic. In fact, the patient symptom resolved. So nothing over there, except a bit of hypodensity. Maybe this one, a bit of reperfusion hemorrhage. So going to case number, so basically case number 2 is a case of a patient with non-disabling, but if you have CT perfusion, will you treat such patient? And this patient, after 24 hours in our stroke care unit, the patient had paroxysmal AF. So this is cardioembolic stroke. And for case number 3 is slightly more difficult, but it's common in our region in Asia. So 45 years old, a lady with primary hyperaldo and hypertension and dyslipidemia. She had multiple recurrent right-sided hand weakness and facial symmetry. For us in Asia, then you already know the diagnosis, multiple recurrent weakness and facial symmetry. This is not a seizure because of this stroke discussion. So blood pressure is 140 to 180 over 90. And the heart rate is 90 regular and glucose is 5 millimole. So this is the CTs. I'll show to you the baseline scan first. So she had recurrent stroke. So this CT scan plane. You see there's a frontal ACA territory infarct and a bit of MCA at the watershed area. And yeah, apologies, I don't have the DSA and the call CTA proper in this case, but bilateral MCA is actually absent distally, proximally, sorry. and the ICA tapered distally. So this is the CT perfusion. You see ACA maps more to the left side, so nothing on the right side, well compensated. It's actually bilateral. And in this case, this is a Moya disease. Yeah, and she had a bypass. This neurosurgeon called me, and the BP at about more than 160 over 90. Remember CT perfusion just now. And this is CT scan plane where the patient became aphasic. The BP was 170 over 100. That's normal for post-bypass, superficial temporal artery direct bypass to the MCA. So STA MCA, then myosin angiosis, the indirect bypass. No seizure, but she had aphasia and right hand weakness. And when you see the CT perfusion compared to just now, homogeneous a bit, that was when she had an acute attack. And now post-bypass, it become not as homogeneous. Okay, and you see the CBV is on the increasing side. So what we do during that time is basically we just control the blood pressure a bit to less than 160, 140 to 160. There's no clinical trial for this, but this is hyperperfusion with hypertension. After about a few days on controlling the blood pressure, the patient can speak again. And the last case here, case 4. This is also interesting. 51 years old, known case of nasopharyngeal carcinoma, had history of radiotherapy more than 10 years ago. Presented with altered behavior, unable to see. So basically, there's a left homonymous hemianopia. That was 7 days prior. Already visited another colleague, a physician, not a stroke neurologist, and not convinced it is a stroke. And even the current team, when referred to me, they are not convinced this is a stroke. So this is a scan. We'll go to this one. We go to the CT scan plane first. This is again a recent case. So the CT scan plane you see here, that's the history just now. Clinically, we know it's sudden onset, altered behavior, and left homonymous. So it must be something on the right. Just imagine without the CT perfusion, in this case, because of time, then I'll put the CT perfusion over here. And I'll just stop here at the temporal region. So for the uninitiated, you see the CT scan plane looks a bit quite normal, but this is not normal. So you go to the CT perfusion over here. This is again the time to peak. This is delay time, and this is the MTT. This is CBV, and this is a CBF. Now, you don't have basically reduced CBV or reduced CBF. In fact, you have increased area of blood flow in this case. Can it be a seizure? Or can it be still a stroke? So when we examine this patient, the left homonymous hemianopia, which may be there before, was no longer there. And this is at day 7 CT scan. If you window properly, maybe you can see the abnormality over here. So this is still a stroke with reperfusion, the one that I told you just now. So there's increased blood flow over the previous stroke area. And this is the scan on the day of called stroke. He had an MRI in a private center. So this is, just scroll a bit for the proper DWI P1000. Okay, so DWI, this is the ADC. So you see the DWI, acute stroke during that time, and this is the flare, which is concurring during that time. This is a SWE, and you see the thrombus over there. This is the SVS, so susceptible vessel sign. So this is basically a stroke at the temporal area. And the reason for the stroke, with the reperfusion just now, the reason for the stroke is here. So you see the patient had a ECAT, so extracranial carotid disease, post-radiation. There's no other radiation necrosis in the brain. And with the reperfusion, although this patient at day 7, actually we are quite confident we can go, maybe earlier for the CEA. We don't need to wait too long. However, because of in Malaysia, sometimes it's a bit difficult for us to get consent for this, and he went for the CEA at day 12. So we didn't wait for a long time because of despite the stroke is quite significant size. So we went in and successfully with no hemorrhagic transformation. So there's a lot of utility of CT perfusion, and CT perfusion most of the time we only use it for less than 2 minutes, but the skill and you need to be able to interpret it as fast as possible because of time restraint. So that would be the last case. I think this is my email if you have any question, and you can discuss during the Q&A. I'll stop sharing. Thank you.
Thank you very much, Dr. Asira, for this nice case presentation. It's very helpful what you present, how to differentiate between hyperperfusion and hyperperfusion. My question to Dr. Bandian, because I think what you did in India is very impressive. What is the most challenging obstacles that you faced during the period before starting your stroke research network?
Yeah, so the number one was to convince the funders. It took almost 2 years of multiple meetings with experts to convince them that it is very important for a country like India. We have our own unique problems. If you look at most of the trials, the global trials, very rarely they include countries from Asia, maybe Singapore, Malaysia sometimes, and Japan and Korea. That's all. The entire South Asia or part of Southeast Asia is not touched. So we don't know the applicability of those trial results to our population. So it was very important to tell them that it is unique and we can answer our own questions. And the track record really helped us because we had completed that large trial, and that really helped us to convince them that it is an idea that we should pursue. And if you look at even in developed countries, they're not able to sustain, except the NIH Stroke Net and probably NHR UK. Beside these two stroke trial networks, others were not able to sustain it for a longer period of time. So we have got assured funding for the next 5 years. So, so the most challenging thing was to convince the funders. Once we completed the 5 years and successful 2 trials, and the ongoing, while they were reviewing the trials in the year 2, year 3, we started working for the phase 2. So that we are able to receive the proposal from all the PIs, and it went through a review process, and they were presenting before the experts, and finally it was shortlisted. So it was phased out very well, so that it doesn't stop abruptly at 5 years and then we don't have any other trials to go. So I would say number one challenge was convincing the funders. Second was to bring people together. So normally the collaboration doesn't really happen. Everybody wants to be with their own data, single center study. They don't want to share the data. But this was very good, probably, among the neurology group. I think stroke is the only group that we are so cohesive, and we help each other, we support each other. Compared to epilepsy or movement disorder, they don't do multi-center studies. Yeah.
And what about publication policy? So you put the name of the first author, second author, senior author. How you work with this?
So this is one of the important things we finalized as a group. So the primary paper of the trial will be under the name of collaborators. And the PI in the list of authors, the PI will be the first name, and based on the number of patients that they recruit. So the order of authorship will be decided accordingly. And there will be a core group, 2 or 3 people. The PIs would be very actively involved. They'll be there and as the first lead authors, and then will be based on the number of recruitment. So primary paper is always collaborators under collaborators heading. But the other secondary papers, the individual PI will be the first author. They will write, and they can decide, whom to involve. And finally, the list of co-authors, the co-investigators' name will be there. But in the secondary papers, we are given the freedom for them to be the first author, and whoever wants to contribute to that paper, they'll be listed as authors.
Thank you very much. Thank you.
Okay, so I'll direct the next question to Dr. Asiraf. One of the members from the audience wants to know, I understand that your protocol is to do a CT perfusion for all your patients. Please correct me if that is not correct. All stroke suspected ischemic stroke patients. And the question is basically regarding the utility of the CT perfusion in obviously resource limited settings, and also when you are dealing with minor stroke, like one of the cases that you presented, or in the early window, if you have a patient with an excellent aspect score, would you still consider doing a CT perfusion before taking the patient for a mechanical thrombectomy in the case of an LVO?
Thank you, Maria, for the question. So basically, in our setting, majority of our patients will have CT perfusion. We protocolize, as I mentioned just now. Why we need to protocol that? This is to reduce the discussion duration. So, without the protocol, there will be like, okay, you need to decide, or this patient for CT perfusion, you use about 5 to 10 minutes just to debate on the phone about the indication for the CT perfusion. So we make it as a protocol. However, when there is a stroke neurologist, because we only have about 3 stroke neurologists in our hospital, and even throughout Malaysia, there's not too many. So basically, if we are around, so sometimes we just keep the CT perfusion as we are very confident with the occlusion. However, the call thought-provoking, as mentioned just now. So basically, for the resource limited, I totally agree where you can use just the clinical assessment. Clinical is very important, and then the CT scan interpretation aspects. If you practicing that, I think that's not a big problem. But going back to the NINS and ECAS, it was not there to prevent you from treating. It is there to guide you. And wanted MCA, 50% PCA, something like that. So you need to have a look, and that will also require a bit of experience and learning curve. The other way that maybe in the future, with the influence of Professor J.R. Pandian, so maybe we can then try to look into algorithm where just single CTA, single phase CTA, automated interpretation, or even a multi-phase. So there's I think in the Calgary group again, trying to create an AI to create similar maps like CT perfusion, but they are not CT perfusion. They're in fact just a multi-phase CTA, and that will be cheaper and much more feasible. But again, the scan maybe not as sophisticated as my current scan, which is 640 slices, but you need like 256 or 128 slices scan. So but yeah, the thing here that I just want to show a few utility of it. It's not a must. Having a CT perfusion and to admit is actually a luxury. But over time, when you being trained, then you can have your own eye as CT perfusion. You have your own AI. That would be my sharing.
Okay, thank you. So just two things that I'd also like to kind of mention here, and also hear your opinion about it, and also of the other panelists here. So now this year we had at least two other published studies and one from last year for the low aspect and the utility of thrombectomy in that low aspect. So we are dealing with even large cores, and we are able to show that even opening up those blood vessels with those large core infarcts, it has its benefit. So there is that aspect which is kind of making the CT perfusion less of a driver, because because then you know that even if the core is larger than what we previously thought was safer, it may still be worthwhile. So that there is that aspect. And then there is also some data now on just doing a plain CT in the late window. And the CLARE study has kind of compared, the utility of a plain CT to that of a CT perfusion or an MR in taking a decision, even in the late window. So how do you look at that data? Because I feel that data may have wider applicability as we scale the intervention to the larger stroke population.
Yeah, thank you, Maria, for the question. And I think I totally agree with you. And with the recent clinical trial, you cannot deny it anymore for the called low aspects. Remember, this is again early ischemic changes, not established stroke, which is big enough. Then you don't need CT perfusion, and even in late window, you don't need CT perfusion if the CT scan is very, very nice. So the aspects is 8-9, then you just go for it for endovascular thrombectomy. So this is again my opinion. Previously, we use it for even to extend endovascular thrombectomy, but we know that we don't need as much. The paradigm that I just want to share just now, it has the called etiology diagnosis over there. It has a prognosis and also precision of treatment, but it's not something that you need to depend 100% of the time. But that's what I think at the moment. And
but it's a great decision support tool. It's a great decision support tool. It just gives you so much more confidence going in,
True. Yeah,
if you have that on your side.
Yeah, but again, called like recently when we have a patient with CT scan looks at the early CT changes, is going to be a big stroke clinically correlating, we don't wait for distribution to come up. We just send the patient for endovascular thrombectomy. We have access for fast EVT. For large core, we need to have access to fast EVT. Slow EVT, we won't make it, as you can see the first case just now. So yeah, we had a CTP, then a large core. So what? So we just proceed for it, and that's evidence based. Yeah.
So probably I'll also just comment on this topic. Now, for us, we are a private academic teaching hospital, and for us is a cost. So we have multiple protocols. So if they are within the window period, we just do plain CT, CTA, and just take a call. And but many of the patients come after 4.5 hours. Then we need to use some of these techniques and sequences. So we are highly selective. Just see where we can cut down the cost. You want to do MR and flare, and just see an MRA, and depending upon what time period they come. So of late, we have, after the publishing of these new trials, we have done a couple of large core thrombectomies, and probably one patient did very well, but the other remaining two patients, they finally landed up with hemicranectomy and longer recovery periods. So we have to be really careful and select patients, particularly in this category. Whatever image sequences and techniques that you have, we need to use it wisely. And
yes, very true. Okay, Dr. Alzawahmah, do you have any questions for Dr. Pandian?
Yes, there is one question from the audience, a very important question to Dr. Pandian. is about these stroke network. Did it improve on these trials, especially phase 1? Did it change the health policies? It's very important that research used to change the health policy regarding the access to care, regarding the transfer, regarding a lot of things that you need to change in the policy, so you do trial.
So the trials were funded with a clear objective that it should improve the health outcomes of patients. So the Sprint India trial, the secondary prevention trial, where if we had changed to a 3 years follow-up or 4 years follow-up, we would have achieved the primary outcome. And but whatever lessons that we learned, that mobile health, there are ways to use. We came to know that text messages are not working. They get fatigued. Repeatedly you get messages and they get fatigued. They just cut your call and they may not read the text message. Videos are interesting, and we need to make a very short duration video. We had 2 minutes video. Probably that also is too long, and based on the process evaluation. So with this, we are able to tell the policymakers that health is important, but you need to be highly selective which one will work. And so in that way, all future studies or implementation of findings, the government knows that this is what that will work. For example, this Ayurveda trial. Now when we had this multiple discussion with the Ayurveda group, they say, based on observation studies of 10 patients, 15 patients improve. But unless you randomize and the outcome is blinded, we may not know. So they agreed, and now we have given it to the government. It is not that the Ayurveda therapy doesn't work. This particular protocol does not work. Maybe there are some more other protocols in their medicine that we need to look at. So it is not completely negative. So we are giving information to the policymakers that, yes, this particular protocol didn't work, but we need to see how we can expand this protocol, come up with some new ways. And so, of course, the trials, the 4 new trials that were funded, just because it will have impact on outcome. So whatever we are doing, we are going to give back to the policymakers. This is what we have studied. This doesn't work. This works, and please scale it up in your healthcare system.
Okay, thank you. So one other question, Dr. Pandian, that I have is with regard to the patient retention in these trials, because mostly European Western populations, we are dealing with a more educated, so to say, patients who would understand the importance of staying in the trial, and the understanding level may be different when you are dealing with a low middle income country. Our challenges are quite different. So what were some of those challenges that you faced, in terms of recruitment, in terms of retention into those trials? Is that something that's very valuable that other people could learn from in the region as well?
So our experience, not only in the stroke and also other neurological diseases and even in cardiovascular trials, if we do research in a very controlled environment, follow-up is very good because they get special attention. Whether it's a control group or an intervention group, they get frequent calls. The research coordinators will call to find out what is happening, and they all feel very good. So then the retention is pretty good. Only thing is, anything more than 1 year or 2 years, then it becomes tricky. So what we do is, in order to improve the retention and follow-up, take multiple mobile numbers of patients, relatives, and a couple of relatives, friends, and so that if one person does not respond, you contact the other person. So when we design the trial, when we calculate the sample size, we try to keep for the highest dropout rate. So far, the trials that we designed, we have taken 10% or 15% dropout rate. But in the sprint, we took 15% dropout rate. But what we achieved was 2% loss to follow. So it is pretty good when we do trials and particularly multi-center research studies, when they are participating in a research mode, the follow-up is better.
Okay, that's good to know. Okay, so Van, one other question from you with regard to the setup for the intervention that's there. Tell us a bit more about the setup that you have. Is it more of a spoke and hub model, or are you do you have other primary setups in the vicinity or other comprehensive centers?
So the setup in Malaysia mostly the university hospital, like the place I'm working now is a university hospital in Kuala Lumpur. So we have at least 3 university hospitals in Kuala Lumpur, and they are thrombectomy capable centers. And we have access to the multimodal imaging. Majority of the small hospital will then refer to us. At the moment, we're starting to have our spoke and hub model, and as you can see just now, the apps that I'm using is actually Telestroke app. So then I can access the imaging from my house, because of this is already 1 a.m. in the morning. So basically, for example, myself, when I was in the Future Leader program, we did the call spoke and hub called model with Army Hospital. So they retain as our spoke and hub centers. Yeah. So the patient in my center, so varies disparity in terms of access, because of we are the most senior hospital. As you mentioned just now, we are the first center providing thrombolysis. We have access to sort of unlimited lytics in our centers. So it's free of charge for that. However, endovascular thrombectomy is mostly out of pocket. So it's about $5,000 US. And it's a bit difficult in certain ways for even in my area. So thrombectomy is still a difficult intervention because we need to discuss about the costs so far. And I envy Prof. Jairaj again, because of I will push on for other secondary prevention and also rehabilitation, as Prof. Jairaj did, large multi-centers collaborative network, because of really, I think Prof. Jairaj showed just now, AVERT dose trial. So I'm also the national co-lead for that. It is marvelous, and I agree with Prof. Jairaj mentioned, after the studies been implemented, what will happen after that? So I need to be prepared as what have been done in India. Congratulations, Prof. Jairaj. It's very nice.
No, I think we need to plan when we design the trial. We need to have a dissemination strategies. So it is very important to involve the policymakers that after you complete your trial and tell them this is what has happened, and that will give them confidence, and they will also get some ideas so that they can see whether it can be rolled out in the healthcare system.
Definitely. Yeah.
There is one question already. You typed the answer, Dr. Asiraf. It is about treatment of acute stroke in patients with moya moya. So can you, because it will be more helpful to the audience to hear it from you.
Correct. So thank you for the question. And for the moya moya patients, so this is the, I usually nowadays try call not all due respects to the founder of moya moya, but we call it as sternocleidosis disease. It's quite common. In fact, we know now there's also interest in the atherosclerotic sternocleidosis disease. So with the multimodal imaging that we have just now, So we can really then identify what kind of disease, what kind of tunnel-occlusive, how much the severity without a DSA, without a cerebral angiogram. So that's really helped us in terms of assessing. And recent studies in my center in hyperacute presentation can go up to 80%. In the overall stroke comers is about 40%. So it's very high intracranial disease, and about 5 to 10% is basically Moya variant or severe steno-occlusive disease. So what we do is basically we check on the hemodynamic first. So if the BP is too high, then we try to bring down the blood pressure. But at the moment, we know there's no randomized controlled trial. So you know the guidelines. I hope you know how the guideline is. So and we monitor, and then we start to bring down the blood pressure a bit as what you have seen just now, 140 to 160. We lie flat the patient, good hydration, check the hemoglobin, make sure the hemodynamic, there's no provoking factor. If hypotension, then again, no brainer, we just hydrate the patient. The antiplatelet or antithrombotic are the same. So basically, but there's no proper randomized control for this group again, because of it's rare. So what we do is the usual thing with antiplatelets for secondary prevention. If there is any other comorbidities like hyperlipidemia and diabetes, it need to be controlled because of that's the reason for faster progression. The most common one is hypertension. Following that, in our setting, is basically hyperlipidemia and diabetes. So we control as usual. Despite the controlling the risk factors, the patient had a recurrent stroke with no provoking factors again, which is the hemodynamic. The comorbid is different. So then we'll discuss about the revascularization surgery, which is preferred, the superficial temporal artery MCA bypass, that's the direct bypass, with the indirect combination. The direct will work immediately and be prepared for other complications like hyperperfusion, vasospasm, and the indirect will take a few months to a year to really work if it's successful. The benefit, the question may be asking the whole paradigm, but this is the called Moya make easy kind of thing. The benefit is mostly ICH prevention. It reduces the ICH risk significantly. There is a landmark called, there is RCT for that. However, for the ischemic stroke, is a small scale. Again, but there is also ischemic stroke benefit. At the moment, the clear one is actually ICH. So we have a lot, especially in the adults group, where when the Moya progress, they develop ICH and SAH. The one with ischemic stroke is a bit easier, but you need to have experience to treat the hemodynamic and the underlying disease. That's briefly, Professor Mohamed, I can share with you.
Thank you.
Okay, so I think we'll head for a closing. I'd like to thank all the three panelists here, our two speakers, and Dr. Mohamed for your valuable contribution. I'm sure a lot of us are already starting to think about some of the stuff we talked about today. I mean, there are valuable lessons to be learned from, all the experiences and all the various settings that we work in with our individual challenges. I'm very grateful to our two speakers. I understand, I didn't even realize, Van, that, it's that late in Malaysia, but thank you so much for taking out the time to present here today and to share your experience with us. Dr. Pandian, it's such a pleasure to have you, sir, on this MENASO Cerebrovascular Grand Round, and we hope to see you again soon. Thank you, Dr. Mohamed, for co-chairing this session, and I wish all of you a very good night, and I hope all of us are going away with some